Thank you for joining us today. I'm Patty Gravitt. I'm the Deputy Director of the NCI Center for Global Health. In 2021, in commemoration of both the NCI 50 and the CGH 10 anniversaries, CGH launched this new NCI Global Cancer Research and Control Seminar Series. And in this series, we feature talks by researchers and cancer control experts working in global oncology, and provide opportunities for discussion and collaboration around really impactful and innovative work that addresses cancer morbidity and mortality worldwide. In today's session, I am really happy to welcome Dr. Karla Unger-Saldaña. Dr. Unger-Saldaña is a researcher working at the National Cancer Institute of Mexico in Mexico City since 2014. She's also currently a remote fellow in international health at the Takemi Program at the Harvard School of Public Health. After her postgraduate studies on health systems, Dr. Unger-Saldaña worked for 5 years with a local NGO where she designed and operated programs to promote breast cancer awareness and facilitate access to screening in highly marginalized settings across Mexico. Her research is focused on understanding late diagnosis and delayed access to treatment of breast cancer in Mexico, where the majority of cases start treatment in advanced stages, which is very similar to what we're seeing in many low resource settings. Her findings suggest that the largest proportion of delay is not due to the patient's postponement of seeking care, but to quality problems and access barriers that hinder the diagnostic and referral processes after the patient's first contact with medical services. Want to just take a quick break before I turn it over to Karla. As a note, today's presentation is being recorded and will be available on our website at cancer.gov/globalhealth. You can find information about future presentations on our site and by following us on Twitter at NCI Global Health. We're also going to welcome you to type questions into the chat box that we will then bring to Dr. Unger-Saldaña at the end of her presentation. And so with that, Karla, I welcome you and turn this over for you. We're very excited for your talk.
Thank you, Patty. I'm very excited too. Thank you very much for this opportunity and for your kind introduction. Let me share my slides. Okay. This is what I've been recommended to speak to all of you about today, about the challenge of early detection of breast cancer in Mexico. And the main argument I'm going to try to develop is the following. So I did this slide to summarize before I begin. So we all can agree that breast cancer mortality depends mainly on incidence and survival. And for the sake of this talk, we want to focus on what influences survival, which is basically these three things. And for the sake of this talk again, I'm going to mainly focus on these two: the clinical stage at which patient starts treatment and the access to quality treatment are key for survival. And what influences clinical stage? Early detection. And early detection can be done through early diagnosis strategies or through screening. And these two terms are usually used interchangeably. And so if you take just one thing out of this talk, I wish it was that. That would mean that I was successful. So let's see. Okay. So I organized my presentation in the following way. I'm going to start giving you a bit of context about Mexico. And then I'm going to go full into the burden and survival of breast cancer within our context in comparison to other countries. And then early detection and final recommendations. And really brainstorming with you, I would love to hear what other people think can be done to improve this. So Mexico, as you know, is the southern neighbor of the United States. It's a very large country, both in terms of territory and population. Its life expectancy is 75 years. It's classified as an upper middle income country by the World Bank. It belongs to the OECD, although it has almost the worst health indicators in almost all of them. It is characterized by being a very heterogeneous country regionally in terms of ecosystems, economic activity, access to service, culture, traditions, etc. And it's also known for being very inequitable. So just to give you an example, there's 3 Mexicans among the 200 richest people in the world published by Forbes, while at the same time, more than half of our population lives in poverty, and almost 11 million live in extreme poverty. So let me give you a bit of context about the Mexican health system. It's basically divided in 2 huge sectors, which is the public and the private. And then the public sector is further divided in 2 large sectors, those that are covered by social insurance schemes and those that are not. And so for these ones that are covered with social insurance schemes, this health insurance depends on their employment, their formal employment, and their services are delivered by social security systems that are closed and only available for those salaried workers and their families. And of course, there's a retirement fund, so that's also available for them. For those not covered by social insurance, which would be all of those who are informally employed, which is a huge sector of the economy in Mexico. This means vendors, domestic workers, and even professionals who are not employed at an enterprise or at the government, then all of those are included here, okay? And these people can use health services that are dependent on the federal government or on the state governments. They can do so. These services used to be available for a small quota, and currently the policy is that everything has to be delivered for free. Of course, if there is the supplies available, no? And then there's the private sector, and the private sector is actually used by everyone. It's one of the most used because it's one of the most accessible. And I'm not talking about sophisticated private services, but even the small doctor's office in the neighborhood, which is cheap. It's much used by people because there's shorter waiting times. And these are used mainly using out-of-pocket expenses because the privately insured population in Mexico is tiny, around between 5 and 8% of the entire population. Okay, so after having explained that, I want to mention Seguro Popular. Okay, Seguro Popular was a program that was in place from 2003 to 2018. It started in 2003, and when it was terminated, it covered approximately 43% of the population. Okay, this included only certain amount of diseases, mainly prevention and general basic care. But very interestingly enough, it also had an accompanying fund for protection of catastrophic health expenses. And through time that the program developed, more and more diseases were included. Breast cancer was included in 2007. And this meant that for all of those women who did not have social insurance, treatment became available for free if they got diagnosed with breast cancer. Didn't matter if they had Seguro Popular or even if they were not registered in Seguro Popular previously. If they had a diagnostic confirmation of breast cancer, they were entitled to receive treatment for free in accredited hospitals that were mainly dependent of the Ministry of Health, but also some private hospitals. Okay, and now today, after 2018, we're back to how we were before. Seguro Popular was terminated, and it's the same system that used to work before. The only difference is that now we're supposedly entitled to use these services for free. And of course, there's actually, and there's been complaints shortages of supplies. That's another story, but it's also a part of important part of the Mexican context. Okay, so now I'm going to go into some breast cancer specific statistics. So as you know, in the majority of countries in the world, breast cancer is the most common, but it's not the most common cause of cancer death. You can see that in more developed countries, even though it is the most common cancer, it's not the main cause of cancer death. Whereas in Mexico and other middle-income countries, it is. So in Mexico, as in other middle-income countries, both the mortality rates and the disability-adjusted life year rates have been steadily increasing. Here you can compare it with other OECD countries. And yes, mortality rates are still not as high as in other countries. But what is very interesting to point out in this graph is that whereas in many developed countries, as you can see, mortality rates have been decreasing between 2015 and 2005, this is not the case for Mexico and other middle-income countries, where they are actually stable and increasing. You can see I've pointed out some other Latin American countries, like Brazil and Costa Rica. Costa Rica has had a little bit of a greater decrease, increase, so to speak, but it's really not very comparable with such large countries as Mexico, as Brazil, that you can see have similar behaviors. I want to show you this data that these results that we analyzed very recently. We have just sent the manuscript draft. So we try to estimate, now we estimated the treatment gap. What is the treatment gap? The treatment gap is the proportion of cases that are not being treated among uninsured women. So what did we do? We estimated the expected breast cancer incidence among this population. And then we did this ratio of reimbursed cases by the Fund of Protection of Catastrophic Health Expenses of Seguro Popular divided by these expected cases. And then this proportion was subtracted by the one would be 100% access, right? So you can see that this gap in 2007, when the program started, was estimated at around 70%, and it fell close to 15%. So this means that there was an increased access to treatment, to breast cancer treatment with Seguro Popular. So now let's take a look at survival, because access doesn't automatically translate into survival. If you remember the first slide that I showed you, we need access, we need quality of treatment, and we need early detection. So let's see how we're doing in survival. In comparison to other countries, Mexico would be placed around here. Mexico, of course, is not in this graph because we don't have national population. We don't have population registries, so we don't have national representative data to measure this. But this recent estimation was done using the entire database of Seguro Popular for 10 years of patients covered there. So it can work as a proxy, so to speak. We don't know what the picture looks like for patients that are being covered under social security schemes, though. Okay, so you can see that patients that were treated under Seguro Popular had a survival rate similar to that of Colombia. No? It would have been placed here in this graph. Note that Brazil is up here, so approximately 10% above Mexico. And why could that be? No? So now I'm going to show you with that same data, the proportion of patients diagnosed in different stages. And you can see here in the dark pink bar, the survival rate for early or localized stages, and in the light pink bar, the advanced stage survival. And you can see that we have similar outcomes as Brazil by stage, whereas overall we were 10% below, which probably has to do with the fact that we are diagnosing cancer later than Brazil. In this graph, you can see Brazil with 46% of their cases being diagnosed in early or localized stages, similar to other OECD countries. Of course, over here are the ones that are doing best with early detection, and the highest income countries. And Mexico, you can see that we're much lower in the proportion of early or localized staged cancers, which is where we want to diagnose them so that they have a better prognosis. And what I want to point out even further is, in the last slide, I showed you like the overall distribution of clinical stage. But here I have rolled it out year by year. And you can see that there was no change at diagnosis in these large number of patients, almost 57,000 women who were covered under Seguro Popular for these 10 years. You can see that the proportions are almost identical. So what does this mean? Seguro Popular increased access, but there was no improvement on the clinical stage at detection. Okay, so now let's speak a bit about early detection. And this is like one of the main messages of this talk, which is screening is not the same as early diagnosis. And we often hear that these terms are used interchangeably, the three of them. Early detection, screening, early diagnosis, we use them interchangeably all the time. And in Spanish, in Mexico, even more, because the terms are have even more similar meaning. And so what I want to point out is that they are not the same, and they are actually two different components, which include different sets of interventions, which I'm going to explain in a moment. And early diagnosis is considered to be key for cancer control, not only screening. It's not enough to consider that if you're doing screening, you're already doing something to solve early detection. You need also to strengthen early diagnosis. So what's the difference between screening and early diagnosis? It's basically the target population that you focus on, which is differentiated by symptoms. So a screening service is directed to an asymptomatic population. You do the test to people that are apparently healthy to try to find if there is something going on before they develop symptoms. Instead, early diagnosis strategies are directed to confirming diagnosis, on those people who have already developed symptoms. But the idea is to do so as early as possible before cancer has grown and spread. And something very important to note here is that the vast majority of cases present through symptoms, even in developed countries, as in the UK and the USA. It has been reported that between 60 and 70% of breast cancer cases present through symptoms. And these countries have good screening programs in place, and still patients present with symptoms. In Mexico, this is even much higher. Between 85 and 90% of cases present symptomatically. So we need to be able to diagnose these patients early on, which would mean diagnosing them in earlier stages. Instead of stage 4, stage 3, instead of stage 3, stage 2. And this would make a huge shift if we could diagnose most of them before they had lymph nodes and they were only locally advanced, so to speak, contained. We could give treatment that has better chances of survival. side effects cheaper to treat these patients. So we would gain a lot from doing these things. Okay, this is the breast cancer patient pathway, which, as you can see, is very complex. There's basically 2 points of entry into the pathway, which is either the woman presents symptoms or she gets screened and has an abnormal result. Either way, once it's detected, this woman is going to seek care. And once she seeks care and has contact with the health services for the first time, the diagnostic interval begins. And you can see how complex is this diagnostic workup here in the middle, because she requires a clinical exam by the physician. She requires imaging tests, usually more than one. It's usually a mammogram plus an ultrasound. Sometimes they need additional takes. She's going to need a biopsy, and then this biopsy is going to have to be analyzed through an expert pathologist and processed, of course, accordingly before he can interpret. All of this to get a cancer diagnosis. And in fragmented health systems like the Mexican system, this diagnostic workup gets even more complicated, because this means that each of these things gets done in different visits to different services across different levels of the healthcare system. So it's really challenging, and lots of access barriers can occur here. Okay, and I want to highlight the very relevant role of primary care in cancer control. It's been already highlighted that GPs actually have a very relevant role across the entire cancer care continuum. But here, I just want to highlight their very important role as gatekeepers. They are the ones to whom patients present with symptoms, and they are the ones who can detect cancer early. They can suspect it and refer the patient for the correct diagnostic tests. So these are very relevant. And in the Mexican system, in the public Mexican system, it's these primary healthcare centers that are spread across the entire country that act as the gatekeepers of the system. Okay, now let me speak a bit about what we mean by intervals to care before I show you the data for Mexico. So this is the consensus in the literature, even though many people don't like this term of patient interval, because we think that there is more to it than only patient characteristics. But this is like the consensus today. Still, the time between symptom discovery by the patient and the first medical consultation for these symptoms is considered to be the patient interval. It includes the patient's appraisal of the symptoms and the help-seeking behavior, the materialization of this help-seeking behavior. Once she has contacted the medical services for the first time, the primary care physicians, the healthcare provider or health system interval starts. This is how it has been named in the literature. And this one ends with cancer treatment start. And of course, there's further intervals to the right as well, because now there's also evidence that it matters how much time passes between different cancer treatments, and also time to complete the entire scheme. But I'm not going to go into that for now. And then this healthcare interval are divided into the diagnostic interval and the treatment interval, okay? And of course, out from this classification, we have left out another interval, which is not measurable, which is how soon could we have detected these symptoms. And this has to do with patient awareness, of course, and how they appraise their symptoms, how much they actually touch their bodies, and if they give meaning to what they find as something worrisome. So we really don't know when symptoms appear to be able to detect, to measure this interval, but I think it's important to consider that this is incomplete. This classification is incomplete if we don't take into consideration that there's previous time that can be gained here. Okay, now it has been shown there's every time more and more evidence, and these two systematic reviews are the most recent ones that that give us the evidence that not only the total interval, but also the patient interval or the health system interval delays are associated with more advanced clinical stage. And with this, of course, worse survival. So let me now give you the panorama of early diagnosis in Mexico, okay? So in this study, we surveyed all breast cancer patients that were diagnosed among 4 main public cancer hospitals, 2 of them dependent of the largest social insurance institution, which is called IMSS, doesn't matter, and the other 2 who were treated at cancer centers financed, where the treatment was financed by Seguro Popular, okay? And here and all of this in Mexico City. And here are the time intervals, okay? To my surprise, and I have to be honest, because I'm originally a medical doctor, and so I was trained to think that it was patients' fault to delay care and that they were the ones postponing the care. So to my surprise, the patient interval was only 10 days long, no? The median. So that's like a third of a month, right? And the total interval was 7 months. So this was a tiny component of the total delay going on. And when breaking the intervals further, we found that the longest interval was that of the diagnosis. That is from first consultation to confirmation of diagnosis. And as you can see, the majority of this diagnostic interval occurs previous to the patient's arrival to the cancer center. This means multiple visits, many times to multiple health systems, okay? We also found, because we didn't only interview the breast cancer diagnosis, we interviewed all of the patients that were referred to the cancer service for a breast cancer suspected diagnosis. So in the end, many of them did not have breast cancer. And what we found was that both groups took the same time to be diagnosed. That means that we're not being able to differentiate and accelerate diagnosis and treatment for the breast cancer cases. Furthermore, those that detected their problem through screening it was a lot more probable that they ended up having a benign diagnosis, instead of those who discovered it through symptoms, which was much more common to find cancer among them. So this to add to the argument that when you don't have strong early diagnosis in place and you start doing screening, you make times even longer for those patients who are more likely to have cancer, because they go into the same line. And the main factors associated to these diagnosis delays had to do with quality of care and access. Perceived errors in diagnosis given by the first doctor by patients were associated with longer diagnostic delays, as also were larger number of health services used. By this, I mean that they used different health systems. They would use a private health system, and then they would try to use their social insurance of someone they knew, and at least for a consultation, and then they would try to use the pharmacy next door, and of course the health center of the service that would bring them to a Seguro Popular cancer center at the end. Furthermore, we see that there is a lack of suspicion by primary care doctors, as 41% of these cancer patients were told after their first consultation that they had a benign condition. This is another study. This is a qualitative study where we can see from patients' narratives the experiences of bad quality of care that they endure. So this woman says that when she went to the health center, they told her to take diclofenac, to put wet compresses and ice. Then she went back and she was given another appointment, a medication. She was told it could be an abscess. She goes back for the third time. She tells them that the lump is she has a new lump in the axilla, and she gets told again, finish your medication and come back to see what we do next. So this is evidence of the medical errors and the bad quality that is going on in our public services. This is another one, which is very relevant to the patient interval. This is what patients perceive from their own experiences that public services are like. She says, in the health center, they treat you like an undesirable person. The doctor doesn't even look at you, doesn't examine you. I would prefer going to a private doctor, she says. This is how they envision private care, and this is not always so. Since private care in Mexico is very heterogeneous quality because it's not well regulated. Okay, so let me just make a short comment on screening in Mexico. So in Mexico, it's recommended since 2011 that women get mammograms every 2 years starting at age 40. And the National Breast Cancer Program has focused on increasing mammography coverage since then. Despite these intentions or good intentions, there have been huge challenges of quality problems, very scarce human resources for interpretation, and lack of budget planning for maintenance of equipment. And all of this, plus the very low coverage that remains, and we can't even speak about this as coverage. I would say this is low participation, because this was obtained from a survey where women get asked if they had a mammogram in the last 2 years. Okay, we don't know if they completed the screening process. We just know they had it. And as you can see, this is much lower at 18% than the minimum 70% required to have an impact on mortality. So as we all know, breast cancer screening is a process. And as I said before, it only starts when the woman takes the test. Regretfully, many women think that if they get it, it's done. And if it's abnormal, somebody will come and knock at their door and make sure that she gets diagnosed. And well, this is not the case in public services. And so this study, which analyzes the database of public mammograms of 2011, but it's the best we have, so I'm just giving you this picture, revealed serious quality issues in the screening itself. But then look at the follow-up. Only 16% of abnormal mammograms received their diagnostic tests. And from these, only 44% received a biopsy. So this means that we're not being able to guarantee the complete screening process. And therefore, we're doing really nothing much regarding to screening. And it does cost a lot of money to just get these tests done. Okay, so how do we improve breast cancer outcomes in Mexico? And so this is what I want to spend my last minutes on. So the Breast Health Global Initiative recommends doing resource appropriate and phased implementation. This means not all high income countries are relevant for middle income or low income settings. And there's an order of things. We shouldn't be doing everything at the same time. And certainly we shouldn't be doing screening mammography first before we have other prerequisites. So they say, first, be able to guarantee access to quality treatment, and then strengthen breast cancer early diagnosis. This means clinical exam, imaging, and biopsy, the triple assessment. And how can we do this? There's lots of interventions that have been proposed, but how do we triage palpable disease so that we can manage it fast with appropriate resources? Of course, we don't want to be doing things that countries cannot financially sustain in the long term. We need education not only of the public, but also of health workers so that they can do early detection with quality. And we need to systematically update our diagnostic imaging equipment before thinking about using this equipment for screening. This is an example of a very interesting study done with Brazil data of 2012. And with this, they estimated how many deaths could have been prevented. They compared two scenarios. So in one, they assumed 80% coverage of screening mammography with access to quality treatment. And in the other one, they said, okay, what if we downstaged 80% of stage 3 cancers, stage 3 and 4 cancers to stage 2? Of course, guaranteeing quality treatment as well. And as you can see, they estimated more than 3 times the amount of deaths averted with this early diagnosis strategy in comparison to screening. So this was the patient pathway I presented to you before. So what if we start rethinking about not focusing on screening? What if instead we focus on diagnosing these breast symptomatic women, which are the vast majority of breast cancer cases, as I've told you before? And then why don't we strengthen primary care so that this clinical evaluation is done well? And it doesn't have to be complicated. We don't want our general medical doctors who had just graduated and are working in the health centers to be able to do a full workup of breast cancer. All we need is for them to suspect, and then we need to support them with a system in place that can catch these patients, so that the doctor says, okay, you need to go here where you can be diagnosed quickly. So how do we reduce these times for diagnosis? Now, we could think of diagnostic hubs where all of these things can be done in the less amount of visits possible. Of course, in Mexico, it's a challenge to include the pathology in the same visit, as the one-stop clinics are usually work in higher developed countries. But we could try, maybe in certain regions where it is possible, or in others, share it maybe with a cancer center, but try to work out accelerated diagnosis and referrals to the cancer centers. And this would strengthen the health system as a whole, and of course, early diagnosis of symptomatic cancer, which would also help to accelerate diagnostic confirmation of women detected through mammography, if they were to do it themselves. So to end this talk, these are the take-home messages, which I hope came across. So first, my first point is both early detection and access to treatment are key. If we only focus on one, it will not translate into improved outcomes. It's like how I showed you with Seguro Popular. We increased access, which was a very good thing to do, but we didn't couple it with early detection, so it fell short. The advanced stage of breast cancer in Mexico is the commonplace, as in other middle-income countries, and this is due to long times to diagnosis and treatment start, and very low screening participation and incomplete screening processes. There is a phased implementation of things to be done. And usually middle-income countries, we just want to do everything that high-income countries are doing. And I think this is what happened with mammography screening. But we're losing the point that the majority of patients are detecting when they presented symptoms, and we have neglected early diagnosis of these patients. So we should maybe refocus and start by strengthening this early diagnosis before further investing in screening, which hasn't worked for these last 20 years. Finally, interventions to strengthen early diagnosis should focus on improving access and quality of services. And these interventions are needed at multiple levels of the health system, as I showed you, and they should be context specific. And when I mean context specific, I mean not only country specific, but regions within the country. So maybe for each state, or maybe even within one state, different cities have different infrastructure and human resources that we can use in different ways to try and do something that improves early diagnosis there locally. And finally, it's key to measure indicators, which we often do not, so that we can really know what works and what doesn't. This is key. Otherwise, we'll keep doing things that we think work, assuming that they work because they work in other places, and spending lots of money on them, and not knowing if they're working or not. And then 5 or 10 years down the road, realizing that mortality is still on the rise. And well, thank you. I look forward to your questions and comments. I'll stop sharing, I think, my screen. Yeah.
Great, thank you, Karla. This was fantastic. And I have to say that I see so many parallels in your experience with those that we have observed in Peru with cervical screening. And so I think that there are some very generalizable, implementation issues with any kind of screening and or early diagnosis and getting people to the appropriate care in these middle income countries that really need to be addressed, and probably could find some very common implementation strategies. So, I think there are a couple of ways that we can take questions. There are a couple of questions in the chat that I'm going to read out. And I think that please put questions in the chat and I'll try to capture them and moderate them. So the first question, Karla, was about, how time, follow-up of an abnormal finding after a screening mammogram. And I think you presented that data, but then the follow-up question is whether primary care doctors are referring women for a diagnostic mammogram when they present with symptoms, and what percentage of those symptomatic presentations at the primary care are actually referred.
Yeah. So this is one of the key challenges in Mexico, as in other low resource settings, is that we don't have administrative data being collected all the time in order to know these kind of things. So I'm not able to tell you how many primary doctors, I'm not even able to tell you how many women with breast symptoms go to a primary doctor. And then from those, who gets referred where and what tests are requested. We don't know that. All that I know from my own data is that breast cancer patients, which I have interviewed, and also patients with breast symptoms that have suspicious diagnosis and therefore use cancer services to get their diagnostic confirmation, I only know what they experience and what they were told by the primary doctors. We don't have a universal medical record to see where the patient went before, what they were told. So that's a huge challenge, and it would be really relevant. What I can tell you, though, is from those that I interviewed, there were about 15% of them who were screened, who detected the problem through screening and not symptoms, to be diagnosed as the other ones, which was that graph that I showed you with the Kaplan-Meier curve, where there was no difference in the time interval.
Yeah, and I'm going to just follow up on that answer with a question that I had quickly, which is just, it sounds to me from your, both, what you just said about the lack of the availability of data in real time for people to really understand what's working for them and what's not, as well as your own kind of admission as a physician of your surprise, because you are taught that the patients were the ones who are not compliant, But in fact, they were, that was really a very small proportion of the problem. And it was really kind of some of the challenges within the health system that was leading to extreme diagnostic and treatment delays. So I'm wondering what you think about, what would be the value of having, what people are calling now data democratization, having real-time data at a patient level available to the local health centers that are involved in the continuum of care, from breast cancer, early detection or screening all the way through treatment and diagnosis and treatment. What is the value of having some kind of system, you think, in terms of what are high leverage things that we could invest in and do, to support these programs being successful and sustainable? Would having that information available and being able to feed it back to providers in real time, do you think it would help to change the health system structure at all?
I think it would help if it's done in a way where the data that is being collected is informative to do changes, no? to do things that can be changed. So that it would have to be coupled with the ability to make decisions and make things happen. No, so maybe you need like a deliverology unit or
right,
something that that does something with that information, and not only like, oh look, this is happening. Oh yeah, but of course we need that data. For instance, at the moment, with our changes in the health system, the current government is not monitoring data on anything. So as much as Seguro Popular could have been improved, and I've actually criticized its limitations many times, I don't have a problem in doing that. But we can do that because they had open data, and so we could analyze things, and also they were improving. So there were opportunities to make it work better. Mm-hmm. And now that it has been dismantled, we're all expectant to see what's coming next. So far, we're seeing drug shortages. We're seeing patients. Well, doctors are saying, I have to give them less dose so that I have more medication for more patients. Right. And this, we don't know the proportion because there's no data available.
Yeah, knowledge is power. So there's another question here that is just kind of, and I think you can answer this one really quickly. It's just, again, wrapping their mind around the fact that screening and early detection are not the same thing. And so, the question is about who's the target for early diagnosis? Is it asymptomatic or symptomatic patients, or both?
Okay, I was definitely not clear. So I will try once more. Okay, so early detection can be done through two ways. We can do screening. Screening is directed to asymptomatic patients, to detect pre-cancers or stage 1 cancers, okay? And early diagnosis is directed to women with symptoms with the intent to diagnose them as early as possible in the advancement, in their development, evolution of their breast cancer. Yeah, so instead of diagnosing them when they are stage 3, diagnosing them when they are stage 2A, so to speak, when there's no lymph nodes involved, and it's only a tumor that the doctor can feel, and if he suspects, he can order a diagnostic mammogram right away or a diagnostic ultrasound. And if things went smoothly, these women could be starting treatment in 2 weeks or 1 month. Yeah, which would be a huge change. Mm-hmm.
Right. Yeah. I mean, these things are really, kind of that downstaging as quickly as possible have huge impacts on survival, it sounds like. Here's a really interesting question. Thanking you, everyone's thanking you for your excellent talk, but were there participants in your study who sought care from alternative therapy providers, such as traditional herbal practitioners or religious leaders? And if so, what are your thoughts on the role of those providers in breast cancer management? And if not, Is it because the question was not asked or because alternative therapy providers are not common in Mexico?
No, yes, they all use them. It didn't impact because they all use them. And I haven't done a formal study on this, so what I'm going to say now. But I think what I've seen from my experience, I think patients end up using both. They end up using everything that gets recommended to them. So they do the diet that the neighbor recommends. They take the herbal remedy. They go and seek for the snake venom. They do everything that they get told. Plus, they come to the cancer hospitals. Some of them do delay their cancer formal medical care, so to speak, for a while because they believe much more in other therapies, but it's very few of them. Most of them do both, and they hide it from the medical doctors because they don't like it. But when you ask them, and I ask them, all of them use it.
Right. Yeah, I think it's very common, and it would be interesting to ensure that those activities are not causing any kind of synergistic harm or benefit, or to know whether they're causing any kind of benefit, because even just the de-stress that might be associated, or the psychological kind of reassurance that they have of using something like that could be really helpful in survival, and that could be an interesting kind of way to study alternative medicines as they integrate with oncology, which is something that CGH is really interested in promoting.
I should just add that I asked them before they started treatment, and now I know that once they start chemotherapy, this is a big issue that the oncologist always tells them: you have to suspend everything else you're taking because it can interact with the chemo. So that comes afterwards.
Yeah, great. Here's another question that's interesting. I was curious about the same. What are some possible sustainable interventions that you could implement at the primary care level to ensure patient management and triaging? And I guess I'm going to just follow up on that with a more specific question is, do you think that we have some space to do more innovation around how we get screening and diagnostic results back to patients? Because it seems like that was a big gap of just things getting diagnosed at the hospital but never managing to get their way back to a patient in any systematic way. So what are some thoughts that you have on how we can improve that?
Well, of course I don't have the solutions, no? I'm here to think about possibilities with all of you. Currently, what I think could help, but I haven't proved it, and of course, improving early diagnosis is very difficult to prove specific interventions because you need so many interventions at different levels, which actually end up strengthening the health system as a whole. It's difficult to isolate the effect of each single thing. But what I think has been more successful in upper income countries, what they have done is try to do this, what I called diagnostic hubs. They are called one-stop clinics. And so we could look at an intervention like this. We strengthen primary care just enough so that medical doctors refer patients quickly somewhere where they can be diagnosed quickly and with quality, which actually we don't have. So for instance, today, these medical doctors are people who just finished their career, their medical doctor career, or who didn't become specialized for some reason. They end up working in these health centers, and they refer to what they have knowledge of.
Right.
Yeah, there's no systematic recommendation. So if we could empower them by saying, okay, any breast symptom, you have to send them to this diagnostic hub that is close by to your health center. And then in this diagnostic hub, you can offer quality imaging studies, preferably interpreted on the same day, so that if the patient needs a biopsy, preferably taken on the same day, And so we do all that in one visit. And then we don't even need to get the results back to the primary care. We just need this patient to get a pathology interpretation. If it can't be done at this same clinic, then automatically refer to where it has already been established that the pathology can be done, and preferably already in the cancer center so that she can start treatment. And of course, if we add this electronic medical file information that you were suggesting before to all of it, the primary doctor could just know the result because it has been fed into the system. The patient wouldn't need to come back so that he would know what's going on. Right. Of course, these are very complex interventions. And again, I don't think there's a one solution for the entire country even. We just need to start working from the ground up locally with what we have got in different cities.
Yep, exactly. I couldn't agree with you more. Here's another really interesting question. Could you speak about how could we disseminate these facts that you just mentioned and kind of this phased implementation approach to cancer advocates and policymakers? Both government and civil society organizations seem extremely attached to mammography screening and maybe paying less attention to kind of pausing those efforts until you can establish better early diagnosis and treatment pathways. So what are your experiences with that? I think this is an excellent question.
This was Ana Cabanes, and she is the expert on this. How can we do this, Ana? Because we have done, I think, 30 years of misinformation by NGOs. It was even a huge challenge on the age to start screening, because young patient advocates who had breast cancer themselves started advocating for a screening mammography at 30. And we're like, what? No, it makes no sense. What are you doing? So I don't know. Ideas are welcome, but certainly every time I get invited to a talk, I try to explain the same thing. And it's so hard. Even among medical doctors, it's so hard to change. It's like a paradigm where we have learned that screening is beneficial and we just don't question it. And if you do screening, you are avoiding deaths. We just all assume that. And it's not so simple. So yeah, I think we need to work on that, Ana, definitely.
Right. And I think you presented really interesting data which show kind of the trade-offs and the impact, right? And I think kind of having some simple tools that we can work people through different scenarios, right, of mortality reduction and showing what the impact is under reasonable assumptions of people kind of having access, that you've got sufficient numbers for the number of screen positives to access, for example, their follow-up care, and how that relates, and again, I think that comes into that phased approach where, we have to do one thing at a time, always with the idea of, do what you can now with the highest leverage for impact, but it's not to say that you can't expand and grow those efforts in cancer prevention over time as the system can accommodate it. So I think that's wonderful. We're at the top of the hour. So Karla, I just want to thank you again. This was such a fantastic talk. I think it gave such a really clear picture of some of the just, almost simple, non-technological kind of, challenges that we face in trying to get evidence-based interventions, into even upper middle income countries, the heterogeneity. I really loved your point about this needs to really kind of start at the ground